Okay, I will have a separate iPad tablet open with the chat window, as opposed to any special Q&A window in case you want to uh, write down your questions as they come up, and then we'll probably end up answering the questions at the end. Also, you can speak up, unmute, and interrupt me if something is confusing or needs to be clarified as we go along. So this topic today, my talk is what goes wrong during the wound healing of pressure ulcers. I have no conflict of interest to report. So the topic is the pathophysiology of pressure ulcers. They're also called pressure injuries, decubitus ulcers, and commonly called bed sores. And obviously we want to prevent tissue death and improve regeneration. Next is a slide that shows some human images of pressure ulcers. So on the one side are category 1 pressure ulcer. That's really like a first-degree burn. It's just a non-blanchable erythema. Let's see if I can get a pointer. Pointer options, laser pointer. Okay, and that's called a category 1. In today's talk, I will not focus on the category 1s. I'm going to focus on the higher category. On the side here is a patient with multiple pressure ulcers in multiple locations, heel, upper trochanter. The thing I want you to realize that first is that pressure ulcer patients are most of the time not diabetic. Of course, some are both diabetic and suffering from pressure ulcers, but these are not diabetic ulcers. These are not venous stasis ulcers. These are not, there are many different types of chronic wounds, and pressure ulcers are their own condition. They have very high incidence, very high prevalence, very high burden to society in deaths, often through septicemia, and cost of care. These are United States numbers, but numbers are obviously cost of care is extra high for a system like the United States, but the incidence and deaths are remarkably similar across Japan, Europe, the United States, and advanced economies. I should also say it's just pressure ulcers are very high risk for anyone who is bedfast or chairfast. And in advanced economies, we have roughly 1% of our citizens who are using wheelchairs. Okay, so why do they heal poorly? Why are they chronic wounds? Are they just ordinary wounds, except they have setbacks during healing? I mean, if you have enough setbacks in your life that cause you to be bedfast or chairfast, then they may also cause setbacks in your ability to heal. For example, advanced age. There could be a wide variety of comorbidities. Even if someone is not outright diabetic, they may have high blood sugar and vascular, poor circulation, bacterial growth, and then re-injury is a common issue as well. So that means reloading the location. The location of a pressure injury is, by definition, where there has been pressure, so where an immobile patient rests their weight. And if the patient places their weight back onto the same location, onto the hip or the seat or the heel of the body, then they can get a re-injury. And so that might be part of why they don't heal well. But in this talk, I'm asking, maybe there's something about the pressure itself, about the form of injury, and if we can find something about the injury that can help us get leverage for the regeneration. So we're taking an experimental approach with animals. We place a pair of magnets over the dorsal skin fold of mice. This is a small millimeters of diameter, but it goes through multiple layers, and so we can see the interplay between tissue types. Epidermis and dermis, then there's fat, a layer of thin muscle called the paniculus carnosus, and connective tissue, which is the loose areolar tissue. And in this study, we're going to look at the lower layers, such as the paniculus carnosus muscle, and not just the epidermis, not just the re-epithelialization. And I'll point out that humans have a layer of pedunculus carnosus muscle at the heel, which is, as you saw in that photo, a common site for pressure ulcers. And if there's time at the end, I'll show you more about the heel of human muscle. So hypothesis one is that the poor healing of a pressure ulcer doesn't require the usual suspects of poor wound healing, such as old age, hyperglycemia, infection, or reloading, re-injury. I'm predicting that in the deeper injuries like muscle and in layers beneath the skin, there's going to be poor healing even in germ-free mice or specific pathogen-free conditions. Hypothesis two, that there's going to be something about the pressure itself that causes a dysfunction we can see early. Now, the reason I make this explicit is not to bore you, but because chronic wounds are typically described, like if you go to the Wikipedia website on chronic wounds, they're described as getting stuck in the inflammation phase, as if the problem is at the transition from inflammation to granulation. And this hypothesis says that the abnormality is going to begin from the injury, not from the inflammation phase. So to test the poor healing, we're going to conduct everything in a clean room. So these are specific pathogen-free conditions. The mice live their whole lives as if in an operating room. And the results show that if we go through wound healing milestones, this is a Gantt chart, a normal wound, and for normal, what we did is we killed off the underlayers of tissue at the scruff of the neck in the mice by injecting a toxin. So this is a snake venom, and it's called cardiotoxin, and it's a very commonly used animal model of regeneration in the field of regenerative medicine. So we did this type of killing. It certainly kills it's what almost liquefies it. It certainly kills the tissue, but then the regenerative process is quick. It actually is fully regenerated by 16 days, even though the Gantt chart only has the 40 days stated here. So it's quick. Pressure ulcers have a delay or a failure at each of these milestones. So that was in not just germ-free conditions, well, specific pathogen-free, it was also young, healthy mice with no comorbidities, no pre-existing conditions, and the wound was placed in a location where the animal's cannot possibly put weight on it. So then we dissect deeper layers of the tissue at day 3 to see, is there something abnormal happening sooner than inflammation, than the transition from inflammation to granulation? So the toxin-induced wound shows epidermis, dermis, the dermal white adipose, pedunculus carnosus layer of muscle and loose areolar tissue, and you can see the muscle, the dead muscle, is swarmed with immune cells infiltrating into the dead area. And pressure ulcers are different. The tissue, first of all, it's compressed. So after it's been in the compression-induced death, it doesn't fully spring back. So it's lost some elasticity, so it's a thinner tissue. And second of all, it's redder. This is in H&E staining, so it indicates lactic acid, and you would expect lactic acid in ischemia. But then let's zoom in to the muscle layer. Both muscles are totally dead, but in a normal wound, 3 days is actually a pretty long time to have dead tissue, so it's swarmed with immune cells. The pressure ulcer, there are no intact immune cells. There are some fibroblasts that appear dead, and there are some dead immune cells in the adipose, but there are no intact, viable looking immune cells in these sections. And if we do a quantification, there's 0 or minimal number across 7 replicants. let's see. So what we've learned, the lessons we've learned so far is that pressure is causing problems. You don't need comorbidities and complications. And secondly, that the immune cells are dead. Other markers that we see in the area of death are incredibly high levels of oxidative damage. We also see extracellular traps, or I should say markers of extracellular traps. I'm not going to claim that, and I'm not going to go into detail with that because it would take more evidence to really conclusively establish that they're extracellular traps deliberately as opposed to just leakage of factors. Okay, so what is going on? Why is the immune system so? Why is the immune system killing the cells? What are dying of oxidative stress, or they're committing suicide in some way? We know that poor healing can be caused by things like diabetes, bacterial infection, poor circulation. But let's look at hemoglobin release. So hemoglobin alone, like a hemoglobinopathy of sickle cell anemia or beta thalassemia, is enough by itself to give people chronic ulcers. So what's that? This could be a muscle fiber rupture. This could be a blood vessel with red blood cell rupture. But in any case, when you have an extracellular globin, it causes a number of harsh consequences, mainly oxidative stress. But iron is also can also feed bacteria. And in the germ-free conditions, that's not happening, but it can cause macrophages to overreact and loss of nitric oxide for angiogenesis. So this is just background. And in addition to that background, I have some previous work of my own. These were originally modeling studies that then looked at how hemoglobin release can cause a flare-up of the innate immune system, because what happens is the immune system weaponizes the hemoglobin as an antimicrobial toxin. So the body has a lot of systems for clearing away debris, for clearing away toxins. But the thing is, we also have an opposite system in, innate immune defense that takes those toxins and says, here, have it. And it actually binds the hemoglobin to the surface of bacteria and lets the hemoglobin produce superoxide for bacterial killing purposes. So this is not as well known as a function of hemoglobin. Obviously, the main function is to carry oxygen. But it has this dual purpose after an injury has occurred. So could muscle be doing the same thing? Another hypothesis I want to bring in is that hemoglobin, if you have a lot of hemoglobin, it tends to cause immune cells to fail at phagocytosis. This has been discovered in endometriosis. So I'm hypothesizing that the pressure-injured muscle is going to have poor phagocytosis resulting in slough, as well as having this myoglobin iron causing oxidative stress. So let's look at testing the next two hypotheses. So phagocytosis won't clear the debris causing slough. We'll dissect at a later time point, and to see whether there's a myoglobin iron problem, oxidative stress from myoglobin, what we're going to do is knock out the myoglobin gene in mice. Okay. So when we dissect deeper layers of tissue at day 10, it's actually really beautiful. Let me help you try to read what this section is showing. On the top here is the slough. So people often think of slough as being bacterial biofilm, but actually what you can see in this slough is that it's made out of the necrotic tissue itself. You can see at the healthy wound margin, There's the normal layers of epidermis, dermis, fat, and muscle. The muscle then gets distorted up, and so that in the pressure ulcer, the muscle that is now dead has been pushed up into the slough layer, and it distorts the margin, which is the launch pad for regeneration to occur. The slough, you can see, contains skin, fat, and muscle inside it. There's work coming out in the International Wound Infection Initiative. That's a multi-continental consortium that's analyzing proteins and proteomics from wound slough. When we knock out the myoglobin gene in mice, bingo, we get a lot less oxidative stress. So ++ is the normal genotype of a mouse, and BOTA-B is a measure of lipid peroxidation, so that's oxidative damage. And when we knock out the myoglobin minus, the level of lipid peroxidation is almost as low as an uninjured control tissue. And we start to see intact immune cells returning to the wound bed, which is more normal. So what we've learned from the first hypothesis that phagocytosis didn't clear the debris is that the immune response is both excessive and insufficient at this early time point, or leading up from 3 days to 10 days. So it's excessive in the toxicity of oxidative stress and antimicrobial things like factors like in extracellular traps. But that's the humoral innate immune response. In the cellular side of the innate immune response, we have not enough happening. The cells are gone, dead, or not performing phagocytosis. We've proven that slough does not require infection, that it can come from necrotic tissue. That's relevant for clinical care because slough is generally used in the clinic for assessing wound state and making decisions about treatment. Another thing I want to point out is that the slough showed no toxicity toward the new cells under it. So at the very beginning, day 3, that was a toxic area with a lot of oxidative stress, and everything in that area died. Totally necrotic region. But over time, it stopped being toxic, which we can see from the fact that newly regenerating cells, the granulation tissue, the proliferating progenitor cells, which are actually kind of sensitive, fragile cell types, those were proliferating and migrating right up against the slough and pushing the slough up. So by the end, it was not toxic. Dysfunction will depend on myoglobin iron. That was the hypothesis, and we did see that knocking out myoglobin restored several measures, not all, but several measures of normalcy to the injury response. And so that suggests that pressure ulcers share a similar etiology with chronic ulcers of sickle cell disease, beta thalassemia, and also perhaps chronic ulcers of venous insufficiency and chronic ulcers of lymphedema. Okay, now let's get wacky and mathematical. This is some background from other work that I've done in theoretical modeling, looking at the damage in a pressure context. So this is just a mathematical simulation up at the top. We have pressure applied and some damage occurs. You might view this as an unavoidable damage. In the black areas, some regions die from pressure. But then over time, the damage causes myoglobin release and oxidative stress, which can cause more death in the region. So this is a computational prediction that a pressure ulcer would have secondary progression of the wound, even after the pressure has been removed, and that the rates and amounts would be dependent on the myoglobin and oxidative stress. This is just a theoretical prediction from playing around with ideas, playing around with equations and simulations. Next, we're going to test it in the mice. Testing hypothesis 5, pressure ulcers are going to have secondary progression dependent on myoglobin iron. So that's saying that the wound will continue to expand and the tissue margins are going to die, not dependent on the primary injury. It's well recognized in thermal burns to occur, but it hasn't been a clinically recognized and widely accepted in pressure ulcers. So the strategy for testing it is to compare wound size after knockout. Simple comparison. So we apply pressure for 12 hours on, 12 hours off, 12 hours on, 12 hours off. And then after that finishes, we start day 0. Day 1, 2, and 3 show wound size over time. This is a surface measure of the external wound. And the wound is twice as big in a normal genotype. In other words, knocking out myoglobin roughly halves the amount of damage. So that seems to say that, that myoglobin is contributing. We're going to see more of this after we try another intervention. We're going to see more of this evidence later in the talk. But so far what we see is that without myoglobin, more tissue survived. Hypothesis 6, that iron chelation therapy will improve the dysfunctional behaviors of the early immune cells. So if we believe that myoglobin is making the environment inhospitable or too harsh, and that the immune cells are not performing well because of that harshness, then maybe we can detoxify the harshness. I should say also that iron chelation therapy has been used before. And let's see, oh, is there something in the chat? Oh, there is something in the chat. I don't know why it didn't come up on my iPad screen. Oh, I know, it was a direct message instead of a broadcast. My chat screen only sees the broadcast. I might have missed it, but why did you hypothesize that myoglobin would cause more damage than hemoglobin? Great question. So let's see. I don't believe that one or the other is, I don't believe hemoglobin isn't important. I just believe, number one, we do have muscle injury. And so that's a concentrated source of myoglobin. And second of all, I think that there is a capacity of the tissue to detoxify some iron and some globins. That's just a baseline ability to clear, to drain, to dilute. And my guess is that knocking out either the myoglobin or the hemoglobin might have been enough to bring the total globin load below the physiological capacity to dilute and to drain. So that's my guess, but I'm not sure. Why another answer to the question, why did I hypothesize myoglobin? The answer is, another reason is because I looked in published reports of patient urine analysis in pressure ulcer patients and found there was significant myoglobin in the urine, and there wasn't a lot of hemoglobin in the urine. Let's see, how did you dress the ulcers during healing? In mice, we don't dress the wounds for the pressure ulcers. So that causes the slough to be a little less moist and slimy than human slough. Let's see, the other thing is that in this animal model of pressure ulcers, they don't heal by contraction. So the skin has enough interaction with the muscle, and then the muscle is not contracting and the muscle is damaged, so that it doesn't heal by contraction the way other types of cutaneous wound healing models would heal in mice. And next, isn't the muscle more vascularized? Isn't the muscle layer under the skin more pronounced in rodents than humans? Great question. So I think there's a lot of differences between mouse and human, and the even more important difference is that they've got so many hair follicles, and the hair follicles have stem cells, and those stem cells really affect, really improve wound healing of all layers, not just skin. So one of the things we found that I don't have in this talk is that the anaphase, telophase of the hair cycle in the mice dramatically affects the wound healing of all layers. And so we need to synchronize the hair cycle, or only apply the pressure ulcers in regions of the skin that have the resting phase white tinted hair follicles. And vascularization differences absolutely are an issue. There's also potential difference in vascularization between the knockout and the wild type. And so every experiment has these uncertainties. Next question. For the end, more of clinical perplexity. Can you comment on the efficiency and reasoning of using sheepskin pads in bedsore prevention? Are they used? Let's see. So I know there are people who do use them. They've been often popular in Australia, and I think there is pretty good clinical trial evidence that we can do better than sheepskin. So we know for sure that something soft, deformable that envelops a region of the body is going to do better distribution of the load over a wider area of space. So pressure is about force over distance, over area. And so if you make a larger area of enveloping the weight-bearing region, so if you're cocooning it, then you will get better weight distribution, but you can do a lot better than a sheepskin when you use the high-tech products. But high-tech products can run you, $200,000 for a high-end sort of robotically controlled mattress. Let's see, can you speculate on what you consider more important? Wools, hollow, springy fibers, weight? Okay, yeah, the envelopment has been, in biomechanics, you can prove how important it is to have the weight redistribution. The microenvironment and moisture wicking properties tends to affect maceration, moisture, and that affects the shear damage. So shear damage is like epidermis, dermis disconnection or blisters from, for example, sliding if you have a tilted bed. And tilting the tilt angle of the bed is a really big risk factor for that type of shear damage. And the next biggest risk factor for the shear damage is moisture. And a lot of that moisture comes from incontinence in the seat region of the body. Okay. And sorry to have to interrupt the talk. I have a student, okay, discuss later. I will I will not read that now, and go back to the hypotheses. I love the comments. Thank you so much for sending them. And if you do send the questions, please send it broadcast to everyone, because that's the only way my iPad will see your questions. Okay, so we have this hypothesis that that iron chelation therapy, so a drug that binds iron, is going to get the immune system to act a little more normal. And why won't this advance? Okay, hypothesis 7. Even if we give the iron chelation therapy in the short term, the impact is going to be a long-term benefit to the regeneration in the tissue architecture. So that comes from the idea that that some of the early disruption of the wound in the immune system is setting the stage for the problems in the tissue architecture regeneration. So another thing I should point out is that iron chelation therapy does have side effects when it's sometimes been injected into muscle as a way of creating delayed release, slower release, but that causes side effects in the muscle. So here we are injecting it into muscle on purpose or just beneath the muscle. Is that going to cause more harm than good? Let's see. So to test the hypothesis, we're going to treat with the iron chelator. It's FDA-approved drug, deferoxamine. And to look at the tissue architecture, what we need to see is the difference between regenerated tissue versus the pre-existing tissue that the mice grew up with. So what we do is use inducible fluorescence lineage tracing. So that means the mice have a gene that can turn on fluorescence protein expression, but only upon induction, and it's only induced in satellite cells, which are the stem cells of muscle. So the mice are born and there's no fluorescence. They grow up to adulthood, there's no fluorescence, and they have well-formed muscle. We induce fluorescence in just the stem cells, but the stem cells are tiny and rare, and so there's still not much fluorescence. And then we hit the muscle with the pressure ulcer, and the stem cells wake up and do whatever level of regeneration they're going to do or not do. And we can watch that incremental effect of the stem cells by seeing what lights up fluorescent, because everything that the stem cells are doing will light up bright colored, and the background is going to be invisible with no fluorescence. Okay. When we give the FDA-approved iron chelation drug, oxidative stress, boom, boom, goes way down, not as much as the myoglobin knockout, but really, really dramatically down. And also, whoa, the diameter of tissue death is down. This is like 35%. But when you decrease the diameter of tissue death that's in the muscle layer, 35% less diameter, that's 58% less area of a circle if it were a perfect circle. So that's a lot less death, actually. So what that means is that the treatment prevented the tissue from dying in the margins, even though we didn't give the treatment until 12 hours after all the pressure was removed. So pressure on, pressure off, pressure on, pressure off for a couple of days. And then after all of that is done, we wait until the next morning to begin the treatment, which is actually a reasonable delay for clinical detection and diagnosis of a problem. And then the intervention begins, and that's enough to still save a majority of the muscle area, 35% of the diameter, from dying. That was really cool. I did not expect that to work so well. We also got a greater amount of regeneration. So the size of the gap in muscle. The gap in muscle is the amount of muscle that simply never heals, never regenerates. You can go to day 90, which is a long time in a mouse. You can go until the end of their lifetime, it still wouldn't heal. That's the gap. And we look at the gap as a diameter and in millimeters, and that gap is way smaller when we give the drug treatment. Now let me show you the tissue architecture, because this is super cool. This is what normal regeneration looks like after that cardiotoxin. So the snake venom kills off all the muscle, but it grows back beautifully, and without fluorescence, you can't even find where the damage was. That's how beautifully it grows back. Perfectly parallel, straight muscle fibers. The reason it's different colors is because the fluorescence transgene, the transgenic mouse, is a multicolor rainbow fluorescence. So you can see that certain myofibers came from one stem cell with the little green dots, and certain myofibers came from a stem cell with the red or a stem cell with the blue. It's a way of seeing the regenerative territories of the stem cells. The point I want you to see here is this ugly mess of what the muscle regeneration looks like. This is the part where it did regenerate. I told you there was a gap, and that's where there's no regeneration. The part that did regenerate, where we call it, oh, that's good, not so good. Look, after it's a pressure ulcer has muscle regeneration. If it hasn't been treated, this is the level of fiber that we get. They are wavy, they are diagonally crossed. If that muscle tries to contract, it's going to rip the fibers. That's not a good situation. If the pressure ulcer gets treated by the iron chelator, this is the level of regeneration we get. It's not perfectly parallel, it's not perfectly straight. There's some stragglers, but a lot of that's going to be viable upon contraction. And so that could also help cushion the region from re-injury. These look like anecdotes, but we do have it quantified for a large number of images and across multiple mice, and this is this holds up. It's pretty cool. Let's see. So we can improve the quality and quantity of muscle, which might prevent re-injury. And overall, it's really a set of lessons that we've learned. They're all interrelated hypotheses about what's going wrong. That there's this damage from myoglobin and oxidative stress that then causes a whole lot of other things to go wrong. Phagocytosis fails and regeneration fails. We're at 40 minutes, and I'm wondering if you normally go to like 45, 50 minutes, or normally go to an hour. There's another little little module I can add about heel muscle. Can I get input from?
Yeah, it's up to you. You could take a few more minutes, and it would be good to have some time for question and answer period as well, because people may hold their questions at the end. So another 10 minutes you could go perhaps.
Okay. Okay. Do human heels have a paniculus layer? A textbook would does not mention any muscle in this region, and if you do an H&E stain, this is what you would see from heel tissue. We did a study of 8 cadavers, elderly, with microdissection, and we're asking, could this be more than just collagen septa? And the answer is, with staining of Mason's trichrome, yeah, that's muscle. That turned red. The collagen turns blue. And if you zoom up close, you can see those are muscle fibers. The size of that muscle is really, really small. So the thickness is between 0.5 millimeter to 1.7 millimeters, so that's very small. The muscle we studied in the mice was also incredibly small, and so the vast majority of the wound tissue is not muscle. The layers are mostly not muscle, but the existence of muscle in the damage is enough to cause the myoglobin iron to be detectable at all of the layers. So the whole wound gets fused with the myoglobin-derived iron. And there may also be hemoglobin-derived iron as well. And that does not happen, that does not require a huge amount of muscle, just a small amount of muscle, which is the amount that humans have in the heel, which is the second most common location, a really major location for pressure ulcers. Most studies, like epidemiological studies of pressure ulcers, tend to look at all locations rather than just a study of heel ulcers. But because we have this anatomical study that's just for heels, I looked, and there was one Swedish study of just heels, and they found that they did a survey of everyone presenting to an emergency department of a hospital, and they found that when they focused on people who were over 70 years old and who had some degree of neurological symptoms, that population had already 9% had heel ulcers upon presentation to the emergency department. And then by day 3 of inpatient, 21% had pressure ulcers at the heel. That's not counting other locations of the body. So that's a lot. In most healthcare systems, a high category pressure ulcer is a serious reportable event if it occurs hospital acquired. If it's acquired in the hospital, although from this we can see that the dynamics of acquisition may be a it erupts very quickly, it erupts overnight. But the damage that gives rise to the eruption may begin prior to admission. So does that paniculus layer matter for biomechanics? So I think we've shown it matters for the biochemistry, but for biomechanics, we did a simulation, a finite element model where we take a heel model and we have with or without a paniculus layer. So this yellow layer added or removed. So if it's not the paniculus layer, then we just add the mechanical properties of a soft tissue. So soft tissue would just be thicker if there's paniculus, no paniculus, and we do that side-by-side comparison of a simple model, a simple biomechanics. So when I should say simple, I don't mean that the computer doesn't have to do a lot of number crunching. Of course it does. But what I mean is that this geometry is very crude and simplified. We know that a real human heel is not like this. The reason we do the experiment like this is not because this is a perfectly realistic heel, but because what we're doing is a relative comparison between this geometry that has a yellow layer versus this exact same geometry except without the yellow layer. And it's just the relative impact of a muscle layer in that location. So the heel, the calcaneus is very hard, the skin and fat is very soft, the Achilles tendon is moderate, and what does it matter to have a bit of an elastic layer? Muscle has more elasticity than other tissue types, it's moderately firm. What does that matter? So having a paniculus layer does matter when we do a side-by-side comparison with and without paniculus. We get less displacement, so the heat map shows less displacement, less deformation from a tiny layer. And then in terms of the number of regions, the tiny little volumes in the simulation, the number of volumes with high strain, is much, much lower with the paniculus intact. And the number of regions with high stress, measured in kilopascals for those tiny little volumes, way lower. So there may be some regions that are high stress, but it doesn't, having the muscle layer in the tissue redistributes the load naturally, endogenously redistributes the load so that no particular region is overloaded. So let me wrap up the talk. When we see poor healing of a pressure ulcer, it's of course possible that the poor healing is because of re-injury or biofilm or comorbidities of the patient. But the implication for clinical practice is that when fighting against all of the usual suspects doesn't work, it doesn't mean we have to just fight even harder. For example, normally you have to offload every region religiously, strictly offload a region of the pressure ulcer. But if it seems to get worse, does that mean you have to offload the whole limb instead of offloading the heel? That level of sort of heroic measure at the usual suspects may need to be questioned, because there is a pressure-related pathology that cannot be fixed, at least in a mouse model, if the animal is young and healthy and germ-free and incapable of reloading the wound. It's still going to regenerate poorly. So poor regeneration doesn't mean we have to blame the patient, certainly. We see a serendipitous discovery. I did not expect so much to be abnormal in the early stage injury response. There was an excessive antimicrobial response in the biochemistry, so excessively high levels of molecules, but excessively low levels of cells. So the cells and the molecules of immune response were sort of inversely correlated. The lack of cells gave us a lack of phagocytosis. And so if there's something to like a memorable takeaway message from this, it's that the dead tissue made the immune cells disappear instead of the immune cells making the dead tissue disappear. Our next set of conclusions is about the myoglobin iron. So when we targeted at that, the immune system behaved more normally. We got less oxidative stress and toxicity. We got more normal levels of immune cell infiltration. Now, obviously, you can have too much immune cell infiltration in an overly inflamed wound, but at the time and place where we're measuring it, I think the immune cell infiltration should be viewed as a sign of normal, healthy injury response. So whether it was knocking out the myoglobin or targeting the iron with the drug, these are two independent tests of the general hypothesized mechanism. But because we did this comparison wound, we did a control, healthy control healing with the cardiotoxin injury. And so that healthy control wound shows us that you can kill a lot of muscle and by definition release a lot of myoglobin. And that is not a problem for regeneration if there isn't pressure. So the cardiotoxin injection killed a lot of muscle and released myoglobin with no ill effects. So I'm going to interpret that to mean that the failed drainage is really crucial. The globin release plus the poor drainage of lymphatics and veins may be why we had the chronicity. And if that's true, then it would serve to unify the etiology of pressure ulcer poor healing, the etiology of chronicity, with sickle cell ulcers, venous insufficiency ulcers, which have a lot of hemosiderin, and lymphedema ulcers. Multiple types of chronic wounds. And third, we do seem to have unappreciated levels of muscle involvement, unappreciated in two ways. First is that there really is muscle in some locations where we had not previously looked or documented it in the past, and also that just a tiny bit of muscle death does seem to matter for the amount of iron and toxicity and oxidative stress found in all the other layers of epidermis, dermis, and fat and lucirular tissue. Happy surprise that we could save the tissue margins and get much better tissue viability by administering the anti-iron treatment, even though it didn't even have to. So normally when people talk about preventing injury, it's about preventing problems before the pressure is applied. So this is really innovative because the clinical intervention is after the pressure has been applied. So after damage has occurred, this could be after a wheelchair patient is discovered to have, say, their heel resting on the metal corner of the footrest instead of on the padded part of the footrest, or maybe after a surgery goes unexpectedly long and you start to see purple signs of deep tissue injury for the patient. However, this is all preclinical research. It's everything has been done in mice. People are not mice, well, except for the cadaver dissection, but those people aren't alive. So we are in no way recommending that people quit eating iron. Malnutrition has never solved anything. The drug we use, deferoxamine, carries a lot of risks. It's an inexpensive generic that we could get going for a proof of concept. And what we have here is proof of concept. Taking proof of concept into clinical translation is going to require optimizing and refining the intervention. And I suspect that we're going to need to keep testing different active ingredients now that we know what the measure of success would be. I've had a great team of people I'm privileged to work with. Jana Nasir and Hans Heemskerk did a lot of the work, and I'm really eager to get follow-up comments or contact from those in the audience. You can contact me also at my website.
Thank you, Lisa. People can now ask questions, students first and then faculty. Okay, anything in the chat? I don't see any. Perhaps we can start with the chat. Okay, anyway, I can ask you one thing. So could you, perhaps a general question, what's the relevance of these studies for chronic wounds other than pressure ulcers? If you could just say that to explain it in simple terms, that would be wonderful.
Let's see. So there are a lot of different types of chronic wounds that show high levels of hemosiderin, which is iron deposits that come usually from hemoglobin, but always from heme. But the problem is those types of wounds are hard to study for the mechanism of poor healing, for the reason why they become chronic, because you cannot remove circulation, you cannot knock out hemoglobin. And so there are papers that have shown that some of the pathologies must be hemoglobin dependent or iron dependent. So there is some mechanistic evidence, and the proof from hemoglobinopathies is that you only have to mutate one amino acid in a hemoglobin in order to get the chronic ulcer. So there's some evidence, but there's really a lot that can't be studied in these vascular types of chronic wounds and where the hemosiderin is coming from hemoglobin. So the choice to study a pressure ulcer gives us a heme source and a globin protein source that is myoglobin instead of hemoglobin. We can knock it out. The mice are viable. In case you're wondering, they play, they grow to old age normally, they have a very normal behavioral phenotype, which is pretty surprising. And a lot of people have studied those mice in exercise studies, trying to see if they have different tolerance of exercise. And it takes actually a lot of labs and a lot of studies to find even partial controversial evidence that it impairs exercise. So it's a pretty odd situation where we can knock out a gene like that. But I think what we learn from this one type of chronic wound is giving us some mechanistic understandings that may be applicable to many other types. And then finally, once we nail down exact time and place of events, the exact sequence of why the immune cells aren't doing phagocytosis or things like that, there may, once we know the right answer in pressure ulcers of muscle, we may be able to use the right answer to design just the right experiment in a vascular context with like some, inducible genetics or Cre-Lox recombinase that would allow it to be confirmed in the other types of wounds. But the other types of wounds are just not as tractable to play around with the genetic tools.
Okay, thank you. There are many questions coming up in the chat box. Would you like me to read, or would you go rather read it yourself?
Let's see. So someone had a hand up, or wait, we're supposed to do students first. Why don't you choose the questions, because you can make sure the students and postdocs go first.
Then that's not in the right order. I think I'll just go with the right order right now. So this question is from Dr. Barrett. Did you ever compare local versus systemic DFO application?
No, never did. We don't know how much of the DFO goes systemically, but I suspect it's relatively local for the following reason. Previous study has looked at DFO as a topical dressing, and it does improve skin regeneration. So you can imagine that the skin is not, so if it's just a surface wound without muscle involvement, the healing can still improve with a DFO drug. So that suggests there's a hemoglobin problem as well. In any case, they saw that DFO helps skin heal. We saw that our injections under the wound did not help skin heal. And so it's possible that the DFO didn't even reach the skin. So I'm hoping that it's local, because that would make it more clinically translatable, because it does have systemic side effects.
Okay, thank you. Now the next one is from Ovidio. He has a hand up. Ovidio, go ahead.
Thank you very much. Basically, I put it in the chat how it's the healthcare Singapore regulatory agency different from the ADA, FDA. I will not ask about the Canada where I am, because I'm sure we're basically all looking FDA. From the point of view of getting something that you're working on into an approved clinical use, and how can you use it experimentally at this level? Because obviously you have some results. Thank you.
Yeah. So I haven't worked personally with the HSA very much, but I see two trends. One trend is that the HSA of Singapore tends to follow rather than lead the FDA in making decisions about new drug approvals and new uses of things developed overseas. So new clinical interventions tend to be at least 6 months and sometimes 6 years behind FDA approval, depending on the market share and the price value trade-off. However, that's for overseas innovations, especially if they have a small Singapore population. If no one in Singapore is a champion asking, can you please import this drug, then it doesn't go very quickly through HSA approval. However, if there are Singapore researchers who are part of a development team, such as trying to do some innovative work in cell therapy, then the HSA has actually been really responsive, fast, measuring itself and priding itself on whether it can be a top regulatory agency to eventually try to recruit that type of R&D work to be done in this country for the sake of having a responsive regulatory agency. So they do try to use some of the same ethical guidelines that you'd see in North America or Europe in terms of safety, privacy, and toxicity. But it is a small country with everything located 20 minutes from everything else, essentially, so that there is this potential for more nimble teamwork. So the HSA is starting to develop measures for itself and measure its own performance based on whether it can do that kind of nimble approval process that upholds the safety standards without introducing unnecessary delay.
Thank you.
Okay, why does the paniculus fail to regenerate after pressure ulcers even when other layers have regenerated? Is this a surrogate to recurrence of PU? I certainly believe it is a predictor of recurrence. So I should have been more clear about that finite element study, the computational study of why that, when you have that muscle layer being so important for protecting the tissue from stress and strain, then if that tissue doesn't regenerate, if you got a hole in that, then you're at really increased risk of recurrence. But why does it not regenerate? Well, we know it is related to myoglobin iron. We know that an iron chelation therapy can improve a lot of it. My guess is that the early events are sabotaging the late events. And the early events that I see most clearly right now are failure of phagocytosis causes the a whole region of necrosis to be pushed up through slough, and the pushing up process causes massive distortion of the healthy margin, which is the launch pad for the regeneration. And what you have is after the margin is pushed up, you have part of the muscle wound healing trying to sort of go up along the same trajectory as the healthy living layer. And then you also have another bit of muscle regeneration that's parallel to the surface of the tissue layers. And so there's these diagonal planes of regeneration. And that disorganization, I think, is initially created by the mechanical force of having to expel the necrosis macroscopically instead of digesting it microscopically. But there may be a lot of toxicity that causes helper cells to die or causes repeated attempts at regeneration, and that may lay down part of the, say, matrix and structures with many different partial attempts so that they fail to do the sort of quorum sensing of synchronization over space. And if they each are trying their own thing at different times with partial success, that could be why they get such poor regeneration. Pushed up by the granulation tissue. So it's granulation tissue full of fibroblasts and immune cells that ends up pushing the necrosis off. The granulation tissue is coming up from below. So the sides are still a little bit distorted towards the pushing upward, and the granulation tissue, is coming from luciferial tissue below.
I have another question. So you said it's immune cell infiltration or immune cell death. Perhaps you mentioned that, I didn't get it. Is it what's more affected, infiltration or death?
Well, by the time we open up the tissue, there's nothing alive that we can interrogate directly. So the evidence I'm going to give you is an indirect interpretation of what I think happened based on the markers. So we see a lot of markers that are associated with immune cells. We can't prove that they could have only come from immune cells, but I think they did. I think what happened was there was enormous infiltration of immune cells and the immune cells died. I suspect they committed suicide and died of the toxicity of the environment. And that's why we see so many of these immune factors. But another possible interpretation is that they simply don't migrate well in the presence of the myoglobin iron. There is evidence in patients, but iron overload patients have a number of phagocyte dysfunctions, including chemotaxis, as well as viability and phagocytosis and so on. So could be a mix of all of them.
Yeah, thank you. Very interesting. Very interesting. I guess we are now at 2:07. Are there any other questions? I don't see any more in the chat. Any other burning questions from students? We didn't get very many. One or two people asked, I guess. But any more questions? We always encourage students to ask questions, but they are more shy, perhaps, to come up with. There are no foolish questions. They are all very important questions. Okay, yeah, so we will, it was a very informative talk. I guess I'm sure although they don't ask very many questions, the students really, all the trainees, they vary from master students to postdoctoral fellows. I'm sure they learned a lot. Thank you very much.
Thanks. It's been really great. I appreciate the audience and the great questions. Very fun.
Thank you. And you taking the time from Singapore to, although it's virtual, we all understand the effort you have made in keeping yourself awake at 1 a.m. in the morning. Thank you so much.
Thank you.
Okay, so hope to see you, and I'll catch up with you. Thank you.
See you soon in, if not Phoenix, then somewhere else.
Thank you.
Take care.
Thank you. Bye-bye.